Hello, everybody, and welcome to tonight's webinar titled Nodify Lung Nodule Risk Assessment, a triage tool supporting primary care referral decisions. My name is Robbie Lunt, and I'm the Vice President of Marketing at Biodesics, and it is my pleasure to introduce our speakers today. Dr. Susan Garwood is the National Physician Director of the Pulmonary Service Line at HCA and practices advanced bronchoscopy in Nashville, Tennessee. Dr. Garwood is an early adopter of the Nodify Lung tests and was one of the first physicians to explore the role of the tests in the primary care setting. Dr. Nicholas Cote is a family medicine physician and the Chief Medical Information Officer at Murfreesboro Medical Clinic, which has 4 primary care clinics located in Murfreesboro, Tennessee, just outside of Nashville. Unfortunately, Dr. Cote had a family emergency and will not be able to join us this evening. But fortunately, he's been working very closely with Dr. Garwood on their approach to lung nodule management, so we'll still be able to highlight their early experience with Nodify Lung testing. In today's presentation, we'll cover the evolving role of Nodify Lung testing in the management of lung nodules and how the tests were initially used exclusively in a pulmonary specialty setting, but are increasingly being used upstream at the point of nodule discovery in primary care to support referral decisions and the early identification of lung cancer. There will be time at the end of the presentation for Q&A, so please use the Q&A function at the bottom of your Zoom to enter questions at any point throughout the presentation, and we'll get to as many of them as we can at the end of the presentation. And with that, I will hand it over to Dr. Garwood.
Thank you so much, Robbie. So grateful for all of you taking your time on a Tuesday night to join us. So I am so sad that Dr. Cote is not able to join, but I know he's here in spirit. And he has been along for the ride on this journey with me on using Biodesics and Nodify as a triage tool supporting primary care referral decisions. And so I'll make some comments about my experience working with him and his group along the way. So next slide, Robbie. So first and foremost, we want to talk about why we're all here, the current state of nodule management in the United States. So if we look at the next slide, I think the hardest thing, especially if we're thinking about referring providers, is that the majority of lung nodules are benign. Most statistics will say upwards of 90+% of the nodules that we see, independent of size, so this includes a lot of small ones, obviously, but majority of them are benign. So if we think about really tiny nodules and you're a primary care physician looking at that tiny nodule, it's very difficult to know which ones should be referred and which ones you need to put in surveillance. The issue with that is the smaller the nodule at diagnosis, the greater the 5-year survival. Because we now have the ability to safely biopsy these tiny nodules, it's very important now to begin triaging more appropriately who needs to be referred, especially at a smaller size. If you look to the left of the screen, you will see how important this is. If we can find lung cancer smaller than a centimeter, the survival at 5 years is over 90%. And if you guys know much about lung cancer, the overall survival for lung cancer in the US at 5 years is about 26% survival. And the reason our survival is so low is that most patients are found at late stage when they're symptomatic and their overall prognosis is poor. So when I began thinking about how do we really get the smaller nodules into our clinics for diagnosis, I really began to think what that relationship with primary care might look like and how could we have an impactful conversation about how to truly triage these patients more appropriately. One of the issues with referral, as you remember, I am a proceduralist by trade now. So most physicians think if you refer to a proceduralist, they're going to do a procedure. So what is the risk with intervention? So diagnosing cancer earlier can lead to better outcomes, but there is also a cost with biopsying benign nodules. There's a risk of pneumothorax, there's a risk of bleeding, and there's a risk that you may not get the answer, as well as the anxiety the patient may be going through undergoing a biopsy that may not be necessary. There's a substantial cost, obviously, associated with this. There's the human capital that has to go into the prior authorization process. So as we think about the balance between surveillance and intervention, is there a way to right the scales? Next slide. So when I think about what's going through my head, even as an advanced bronchoscopist, when I see nodules, specifically those that are less than 30 millimeters, how do I know what my clear next step is? Luckily, we do have guidelines. Everybody loves guidelines, but the ACCP guidelines are very clear in nodules that are very low risk and nodules that are high risk. High risk is considered a risk above 65% based on the physician's clinical assessment or a Mayo calculated risk, for instance. Very low risk is considered less than 5%. So there are clear paths forward in both of those scenarios. When we think about what goes into a physician's clinical acumen or decision making, smoking history comes to mind pretty quickly. The size of the nodule, the density of the nodule, obviously if they've had cancer history before, and then it begins to get pretty complicated. Where's the nodule? Where are the borders? What's the family history? Have they had occupational exposure before? What are their comorbidities? How anxious are they? So there are a lot of competing things swirling in our mind to decide really if we want to push that forward to a diagnostic evaluation or a next step. If we're looking purely at the guidelines and we calculate risk, 80% of the nodules are in the intermediate low to moderate risk zone. The issue with that is that there is not a clear path forward. When I ask my primary care physicians, how do you decide your next step? They say they follow Fleischner recommendations based on the radiology report. And when I ask them how they would interact with the low to moderate risk, and what the Fleischner guideline is. If you guys recall, Fleischner gives you 4 options: a 3-month scan, a 6-month scan, a PET scan, or a biopsy could all be considered appropriate in that middle ground. And what I tell them is that's 3 options too many. Okay, we'd love to have a clear path forward in that intermediate group. And if they actually understand that 80% of people fall in that group, it really opens a conversation of how do we really tailor risk in that middle ground. Next slide. One of the most impactful things when I go and talk with primary care physicians, nurse practitioners, even some of my general pulmonologists down in the community, the first thing I ask is, other than your gut and your clinical experience, how are you calculating risk? When we have a true incidental finding, ideally the calculator of choice is one of the calculators such as Mayo. And if we look at a Mayo calculator includes some pretty straightforward characteristics. The first is the size of the nodule. The next is the age of the patient. The next is upper lobe or non-upper lobe. And then the next is spiculated or not, smoking history, just a pure yes or no, and a personal history of cancer, yes or no. If you plug those things in, the exercise I like to go through is that of size. Most of us make gut reactions based on the bigger something is, the more likely we're going to think that it's cancerous and refer. But when things are small, how do you truly have a shared decision making with your patient? And I would strongly encourage you to begin to put calculated risk in your shared decision making commentary in your notes. When you use more specific objective data with your patient and in your medical record, I think it truly goes a lot longer. In this example specifically, both of these patients have the same size nodule, 8 millimeters. The one to the left is a younger patient, and that risk comes out to only 2% risk of cancer, or a very low risk. The one to the right is an older patient, 75, upper lobe, and spiculated with a history of smoking, and that raises the risk to 44%. When you're having a conversation with the patient, let's say both of these patients were in car accidents over the weekend, and they show up into your clinic on Monday to discuss their pain, their bumps and bruises, and you let them know that they have an 8 millimeter pulmonary nodule. And after they get through recovering from their car accident, the question is what to do next. I can guarantee you most of those patients aren't going to remember much about an 8 millimeter nodule. They will remember a conversation about a percent risk of cancer. So if you tell the patient to the right that while we were doing imaging, there was a finding on your CT scan, and there's almost a 50% risk that you may have a malignancy in there. So thank goodness that that scan found that. We would love for you to go see somebody for further evaluation. We can also talk about how a blood test may be able to influence that decision as well. But I would talk about risk not just from size, but get into the habit of calculating risk and putting that in your medical record. Next slide. So what we want to really talk about is that we are not suggesting that a blood test is going to replace your clinical experience. It's not going to replace your education. It's not going to replace your clinical acumen. So I tried to document what's actually happening in my brain when I see a patient with nodule. Right? The first thing all of us do is to take a good history. And that's very, very important. We want to know all the potential risks that could be associated with this patient's history, as well as the events that led to the CT scan. Obviously, if they're a smoker and have a strong family history, have had radon exposure, asbestos exposure, inhalational exposure, all of those things are very important. Silica, sarcoidosis, history of TB, histo, any of those things that might give you a clue about their environmental risk. We also want to know about the events that led to the CT imaging. Obviously, I review incidental nodules with my nurse navigator every Monday. And the most important question we ask is what led to that CT? If that's a patient with IV drug abuse and is admitted to the hospital with positive blood cultures and endocarditis, I'm going to be less concerned that that pulmonary nodule could be a malignancy if they're multifocal, peripheral, and cavidary. So we're not asking you to replace that. We do want you to go the extra mile to look at serial imaging, right? So if you have a nodule that's growing over time, that's a do not pass go. That is increased risk for malignancy, and that would ideally prompt you to refer that patient and let that patient know an enlarging nodule raises my suspicion that this could be a potential malignant process. We also want to know the time frame. You know, how quickly do things move? Do we have stability of that nodule? Okay, if it's a solid nodule and it's been stable for more than 2 years, we don't need a blood test. Okay, that likelihood of malignancy is extraordinarily low in a long-term stable nodule. If it's a ground glass nodule, same thing, and it has not changed size or density, again, that's not a place where we need a blood test to tell us that it's likely benign. You are safe as long as you have followed for 5 years. But if this is truly incidental and all of the clinical factors would suggest that it's not overtly high risk to begin with, you should do a risk calculator. If it's incidental, ideally use the Mayo. If it's a screening patient where you find a lung nodule, a Brock nodule calculator can also be helpful as well. When I go through that process, if that patient falls in that gray zone, less than 65% risk, I use the Nodify test to help inform me on that next step. The Nodify test, like we will show you, has some clear guidelines for its clinical utility, and specifically that is in small nodules. And some physicians will say, well, gosh, I know what cancer looks like. And I would, most of the time when cancer is above 30 millimeters, we all know that is now a mass and that needs evaluation. Or if it's a larger upper end of that range. So what we're asking is to truly focus on the less than 65% risk patient. They need to be over 40 years of age and not have a cancer history. People often ask me how I utilize PET scan in the evaluation of pulmonary nodule. Again, this is a personal preference on the way that I evaluate my patients. It's not uncommon that they may already come to me with the PET scan result, and we'll talk through kind of how I utilize that as well. If the patient is coming to me primarily for nodule and they've not had a PET scan, I will use Nodify as my first option to let me know if that patient is truly low risk, less than 5% risk. I will often skip the PET scan up front. If I do use a PET scan. I will use a PET scan not to tell me what to do with the nodule, because we will show you sensitivity and specificity for PET scan with small nodules is not as good as we would think. I love to use PET scan to look for any extrathoracic disease and to evaluate for nodal involvement. So if I do decide to take that patient forward to biopsy, that I already know everything I need to evaluate at that time. Next slide. So if we think about how does this test perform against PCA's physician's clinical acumen, and how does it perform against the top 4 calculators, which are Mayo, the VA calculator, Brock, and Herter? And more specifically, how does it perform against PET scan? Because I think when I was trained, if it was PET positive, we should do something. If it was PET negative, we should wait. Okay. Now that can be difficult depending on what part of the country you're in. I'm in histobelt, so we have a plethora of patients who have histoplasmosis. Granulomatous disease may be falsely positive, right? However, carcinoids, low-grade adenocarcinomas or other slow-growing tumors may be PET negative. The smaller the nodule, the less accurate a PET. If it's not solid, non-solid lesions only have a 46% accuracy. And those that are less than 10 millimeters, okay, when we start to get really small, it's almost a coin toss on how accurate that is. If we look at how Nodify XL2 plots out in the area under the curve, you see it outperforms all of those. So when a Nodify XL2 tells you that that nodule's negative, that accuracy is very good. Next slide. So let's talk about the test itself. So it has 2 different components to it. Next slide. The blood-based strategy involves first a Nodify CDT test, and this is a blood-based autoantibody assay, and it is the rule-in portion of this two-portion test. The specificity is 98%, which is excellent, and the positive predictive value is 78%. Meaning 4 out of 5 times, if it says that there's something worrisome there, it is correct. And again, if we think about the positive predictive value of the PET scan we've just shown you, it's far less than that. We always want to make sure you understand this is not a new test. I've been using this test since about 2019, and it is fully covered by Medicare. And we will talk about any questions with commercial insurance. With Medicaid, again, they have excellent financial assistance, and the majority of commercial payers now cover this. Please feel free to ask us any payment questions, and we'll show you some of the publications and presentations. This has been a long-standing, well-studied, and validated test. The second portion of the test is what we call the rule-out portion of Nodify. If your CDT is positive, that's the end of it. It won't go to an XL2. If there's no antibodies to suggest cancer, it will reflex to the XL2 test. And we will show you those are going to be based on blood-based proteins and to help us identify nodules that are likely benign. Excellent sensitivity, excellent negative predictive value, 98%. Again, both tests well covered. Next slide. The validated patient population. So specifically with our primary care physicians, we want you to stay within the guardrails of how this test was clinically validated and will be covered by insurance. So we want to make sure that the 4 criteria are met. First being size of 8 to 30 millimeters. Next being a risk of malignancy based on the Mayo calculated risk. You can do a CDT test up to 65% risk, and you can do an XL2 test up to 50% risk. The patient needs to be at least 40 years of age. And for the cancer history, if you have CDT, if you're doing that, we don't want you to have any history of cancer. Again, there's a small chance of cross-reactivity, so we don't want that to be false positive. And I would argue if you have a nodule with a prior history of cancer, my inclination is to be aggressive on those patients and to move them forward to biopsy. We don't want to sit on those, even if they're small, especially if they're new. The XL2 test, you can have a history of cancer as long as it's not lung cancer if it's been more than 5 years ago. The XL2 test can still be adequate in that setting. Next step. So let's look more deeply at the CDT test. So the CDT test is based on 7 autoantibodies, and these are specifically associated with all types of lung cancer, both small cell and non-small cell. Again, that specificity is 98%, and the positive predictive value, 78, means 4 of 5 Nodify high level results actually had lung cancer. We'll talk a little bit more. The results can also come back as moderate, and that positive predictive value is a little bit lower as well. Next slide. The XL2 test is looking at, next slide, is looking at 5 clinical factors. So it's looking at the risk associated with malignancy: age, size, location, speculation, and smoking history. And it is including in that evaluation process 2 plasma proteins, one of which is an inflammatory marker and one of which is an oncogenic marker. So it's looking at the balance of the 2 to see if they can figure out which one is going to win out. Does this appear to be more likely to be an oncogenic process or an inflammatory process? The wonderful thing about this portion is a sensitivity of 97%, meaning only 3% of malignant nodules received a result that was likely benign. And that's far better than our clinical acumen, certainly far better than a PET scan or physician clinical acumen. 98% negative predictive value. Next slide. When I talk to physicians and I ask them, if you're looking at a scan, what is your gut reaction? What is the thing that's going to make you refer quicker? And most of the time, people will say size. The larger a mass is, or larger a nodule is, the more likely they're going to be worried about it. And that is true. If we look at clinical risk, the nodule size contributes about 30% of that risk profile. When we're looking at the XL2 test, however, the important thing I want to point out is that the plasma protein levels carry as much weight as the size of the nodule. So as certain as you are that that large nodule is something to be concerned about, the blood test has just as much weight. And the way I describe it to patients is, I don't want to just look at the scan. I want to look at your biology and have your biology guide me about whether I need to be concerned or whether my anxiety as a physician needs to be quelled some, because the blood test says that this is reassuring and the negative predictive value is 98%. Next slide. So we will go through some interpretation of results, but I wanted to let you know the way that these will come out. We have simplified the report to try to make this a little bit easier to understand. But the XL2 results will come out in 3 different phases. You will have a likely benign result, a reduced risk result, and an indeterminate result. Likely benign, again, means exactly that. You tell the patient that the risk is less than 5%. Ongoing surveillance is just fine. And we want to make sure you follow those surveillance guidelines for solid nodules for 2 years and for ground glass nodules for 5 years. Reduced risk comes back in 45%. And I tell the patients again that the blood test was somewhat reassuring, but did not put you into that fully safe realm below 5%. And we want to continue to keep a close eye on you. And in some circumstances, we may want to do a biopsy. The last category, indeterminate, means the test couldn't reassure me at all. So whatever the risk you started with is still the risk, and you need to consider next steps based on that. Next slide. So when the patient comes into my office, I don't expect you guys to know this level of granularity, but I think it's important when you are referring patients and you get these results that you understand what physicians like myself may do with this information. The first one to the left is pretty easy. If the Nodify comes back high, the majority of those patients are going to get biopsies. The only time I don't do a biopsy and a Nodify high is when I re-image the patient and the nodule's gone completely. One of the issues with the Nodify CDT is that those autoantibodies can be positive sometimes months to years before the abnormality shows up on a CT scan. And that can be a little disconcerting. That should not be a conversation that the primary care physicians should have to have, but it's important to understand that. But the majority of the time, when a CDT comes back positive, I will get a PET scan to look for any nodule or extrathoracic disease, and I will proceed with the biopsy. In the indeterminate group, go back forward. In the indeterminate group, about 35% in that group will also have a malignancy. I will have a shared decision-making visit with the patient. I often will add a PET scan to give me additional information about lymph nodes or extrathoracic disease, and I will offer biopsies to my indeterminate patients. The next group of individuals is reduced risk, but the negative predictive value is still less than 95%. The same thing. I will have a shared decision making with those patients. Again, the risk isn't as high as 35%, but it's still there. And we have a conversation with patients, usually adding a PET scan and discussing either biopsy now or close follow-up. When that negative predictive value is more than 95%, again, I will do close serial surveillance. And again, if it's likely benign, I likely skip a PET scan and do traditional surveillance at 6 or 12 months, depending on their age. Next slide. So what happens in a primary care? How do you take what's happening in an advanced bronchoscopy office and move that one step forward? So next slide. The first conversation is how do you decide? Can we go to the next slide, Robbie? Whoopsie. How do you decide on how to engage with primary care physicians? Can we go to one more slide forward, Robbie? There we go. So a potential workflow for referring offices, when I first discuss how this might be used in their office, again, we'll kind of go through ways to look under the hood a little bit more. But the first is really just to teach not only to physicians, but the mid-levels and even your MAs about when a patient has a nodule, either a new nodule or a nodule that you've been following. Have you documented the Mayo calculated risk in the medical record? You can even embed it in some of your EMRs. You can teach your MAs to do this, or your nurses. There's an app called MD Calc that you can put on your phone or your computer, and you can plug in the things that are components of this. First being the nodule size. And the nodule size that we're talking about, it's okay to use the calculator if they have multiple nodules. We want you to use the largest dimension of the index nodule, meaning if they've got multiple nodules and they're all stable, except for one that's new, we want you to use that one. And if there are multiple nodules that are all new, we want you to use the largest dimension. Smoker is easy, yes or no. Speculation is also a yes or no question. We only want you to put yes if the radiologist uses those words in the radiology report. We don't expect you to be radiologist. So if it says speculation in the report, put a yes. Location, upper or lower. Okay, so if it is in the middle lobe or lower lobe, obviously that's not upper. So we just want you to say upper lobe, yes, if it is there. And then the patient's age. And what we would encourage you is very simply, if the calculated risk is over 50%, say those words to the patient. Mr. Smith, I know you had a car wreck. I know that we're recovering from this, but when we looked at this nodule and we put in the characteristics and your risk factors, it looks like there's over a 50% possibility that you could have something concerning like a potential cancer. I would like for you to go and see Dr. Garwood. That hits very different than Mr. Smith, you have an 8mm nodule. And we'll follow up on it. Go ahead and use the words. That transparency is very important. If the nodule risk is less than 50% and their age is greater than 40, the size meets the criteria, their cancer history meets the criteria, primary care physicians, nurse practitioners, internal medicine, family practice, you guys can order a Nodify test. And the only thing we really ask of you is that if the risk comes back above 5%, again, tell the patient we can't be reassured that this isn't something of concern. We'd like you to see the specialist. And based on the results, if the result comes back less than 5%, the important part is to get into the habit of confirming that you've done adequate surveillance. Even within our country, Nicole Tanner at MUSC published that even with good primary care interaction, over 70%, 70% of the patients in the United States do not get Fleischner recommended 2-year follow-up for solid and 5-year follow-up for ground glass. So get into the habit of documenting risk, talking about the importance of surveillance. Even if it's less than 5%, don't stop evaluating that patient just because the blood test says things are reassuring. But most importantly, have a shared decision-making visit with the patient and inform them that your blood suggests that something important may be going on, and we would like for you to see a specialist. Let's go next slide. We'll come back to the workflow, Robbie. So when you get the report, they've actually used this. Dr. Cote and his group was actually pretty instrumental in giving feedback, because what we want is for the report to be very digestible, very easily readable for anyone to look at. So this is the way that the report will read. The patient information and characteristics you will see on there. The only thing that needs to be observed here is this sliding bar. All right, and if you look to the blown up area on the right, green means good, okay? So green, we call it orangey, yellow, and red. So green means less than 5% risk. Ideally, that means you guys can continue to follow. Anything that's in that orange color is going to be above 5% and less than 65%. And anything that's in red, that high risk, we certainly need to make sure the patient hears those words and is referred. So we're looking at that slide bar there. Next slide. So what we really wanted to talk about tonight was, will this make an impact, right? We just talked about, and didn't actually mention the words, but Gould's paper suggests that at least in the US, there's about 1.6 million incidental nodules yearly, and that's information several years old. So we know that there are even more now, given the preponderance of CT imaging that we do. So we went to a primary care group that is north of Nashville, not within our hospital system. And we began discussing just nodules in general. We'd had some experience with them before, referring for us. We do robotic bronchoscopy, and we would routinely, with our primary, with our PPR team and marketing team, we would go out and talk to these physicians about how great our robot was. And you should be referring us patients that have nodules that are greater than 6 millimeters. They said, great, this sounds wonderful. Okay, it's a very safe procedure. We get good communication with you, we get good service, but we realized that we weren't getting a ton of nodules compared to what we know is out there. So we began to think a little bit differently. How do we have an evaluation about how many nodules are sitting in a primary care office? And what's the level of exposure, meaning even liability, right? So if you sit on a nodule and it's cancer, or it spreads, or you lose that patient to follow up, we've missed an opportunity. So we really began a thought process of how do we educate providers how to evaluate patients objectively the same way every time. And to prove the point, what we did, remember we said 70% of nodules don't get the follow-up they need. We worked with their IT people within their office, and we said, can we look back, or you guys look back in your medical record and figure out how many patients had a diagnosis of lung nodule that did not have follow-up. So it's a still active problem, and there's no follow-up plan or diagnosis. And this particular group, 17 different providers, they looked back 3 months and they found 72 patients that met the criteria, 72 patients that had nodules within the appropriate criteria, that were age greater than 40 without a cancer history like we talked about. They called the patient and said, you have a pulmonary nodule. We've become aware of a blood test that may help us have more information about whether we need to do anything. Not to frighten you, it's 95% of nodules are benign, but this is a way for us to get better information in case you are one of those 5%. So of the patients who got the blood test, so the 72 patients, all of them had the blood test, 57% of the time, it was likely benign. Mr. Smith, your test is very reassuring. It's not 100%, but with good confidence, we're going to continue to follow you. It's very important that we schedule you for that follow-up CT scan But right now, the test would suggest that you're at low risk for malignancy. 43% of the time, that risk came back above 5%. And again, we educated them, Mr. Smith, your blood test suggested that there could be something more going on. We would like for you to see a specialist. Next slide. So there were 31 of those patients. 58% of that group said yes, that they were willing to see a specialist. And we do things by telehealth, so patients didn't even have to travel. And remember when we said 95% of patients are benign and about 5% are malignant in this incidental population. We're not talking about screening. It's kind of like trying to find a needle in a haystack. So we're trying to find that 5% by looking at an EMR, applying a blood test, and having them see a specialist. In this particular case, of that 58%, we ended up taking, and we being myself, took 5 patients to bronchoscopy. So one of the difficulties in the US is that 64% of the time, biopsies are being done on benign disease, right? We really want to spend our time not doing invasive procedures when that patient has a low risk of malignancy. So it's very important not to over biopsy, but also not to under biopsy. And in this particular circumstance, what we wanted to show with our primary care physicians is that we can responsibly help you manage, digest, triage, and funnel who needs to be referred. And remember, I didn't see all 72 of these patients. So we saw 58% of 31, and we only biopsied 5. 4 of those 5 patients had lung cancer, and all of them were stage 1. We had 1 patient with an abnormal blood test that the PET scan was positive, and they had a high oxygen concentration, and were not a good candidate for anesthesia. We presented them at tumor board. Everybody agreed this looks high risk for malignancy. That patient went on to have SBRT. So of the 72 patients, we did not biopsy all 72. We didn't even consult on all 72. We got referred the 31 patients that we were able to evaluate, saw 58% of those, 5 bronchoscopies, found 5 cancers, all of which were stage 1. That's 7%. Okay, so we found the needle in the haystack. We didn't just find the 5%. We actually found a little bit higher prevalence of cancer in this specific group. 7% prevalence of cancer, but all stage 1. What we did with this information was then go to a larger group. And that's really where Dr. Cote's story comes in and how we want to talk about how you might do this at scale. So next slide. Dr. Cote was fantastic. And he said, start with me, right? Like, I don't know. I'm probably not great at this either. So if we're going to look at anybody as president of the group, I want you to look at me. Let's go ahead and look at our medical record. And so we looked back, and he and a few other physicians were kind of our guinea pigs. And they looked back in the past 30 days, and they had 19 patients that fit the criteria. And they were 5 to 14 millimeter nodules. And when they did the blood test, 53% of the time, so 10 of those patients had said that they were okay. 9 of the patients prompted referral. We did bronchoscopy on 1 of those patients, and that patient had a stage 1 adenocarcinoma. And that patient was Dr. Cote's patient. And that patient, he will tell you, he saw them the day after our conversation. And he said, I'm going to get this blood test. I've been watching your nodule. I'm sure it's nothing. He said, these words came out of my mouth. It's not really changed that much. It's probably fine. Let's get the blood test. The blood test came back elevated. I saw the patient, did the biopsy 2 days later. The patient already went through surgery, does not need chemo, does not need radiation. Had we not had that engagement, he was very clear he would have continued to follow. And when we looked at his follow-up schedule, as you can imagine, it was pretty erratic. First time it was good at 3 months. The next time it was around 14 months. And then again, intervals are inconsistent because our life is inconsistent. It's very difficult to follow nodules on a very strict schedule. After this happened, we went and had a more in-depth conversation. So Robbie, can you go back to the operational slide in the beginning? Remember, Dr. Cote is over 4 clinics, There's over 40 providers, and he was our champion physician. He invited us in early on for a lunch. We talked with MAs about doing calculated risk. We talked with MAs about how to draw blood and how to fill out paperwork. But we also talked specifically about the clinical need. Do you know anybody with late stage cancer? Do you know the difference between survival with stage 1 and stage 4? If you're going to ask somebody to do something, tell them why. Okay, give them a good mission moment. Like, what are you trying to change? And that will motivate people to try something different, maybe even try something out of their comfort zone, and share some success stories. And that part is really important. So we had an initial meeting with myself. So we have, ideally, you would have a lung doctor who's capable of doing the biopsies, who could come and talk with these primary care physicians. So if you don't know who that is in your area, you could reach out to your Biodesics reps or message the Biodesics team, and they should be able to connect you. But have that physician come and talk with your group about how they could potentially operationalize this, how they could do education, and how they could talk about the clinic's level of exposure, what that liability could look like, and how you could come alongside these clinics and work as a team. So one of the first things we did was to see what is the level of exposure. How many patients do you think exist in this particular clinic? And so Dr. Cote was very rigorous. He went to his chief informatics officer and IT managers and said, I want you to run these codes. Run R9 1.1, R9 1.8. I want you to run pulmonary nodule. And they have their own internal CT imaging. So he even went one step further. So he said, let's first run nodule, and then let's make sure that it's not the same patient. So let's rule out the duplicates, and then let's cross-reference that. If we can't find a CT associated with that nodule in the last 12 months, they should go to the top of the heap. They looked back 3 years because he was very dedicated. And within those 40-man group, they found 3,000 nodules, 3,000. Okay. And if you think about running the number, so 5% of 3,000 is 150. And he said, I can't sleep at night thinking about those 150 early stage lung cancers that are sitting in our clinics. And I could find them if we could just go and figure out this process. And so he engaged his board. He engaged the broader group within his primary care. So we had a couple of dinners. We reviewed, just like we're doing tonight, the landscape, the products, the clinical opportunity, success story. We really gained buy-in about what would that operational process look like. And we don't want to be disruptive. So how could we potentially work on that? But the first thing is, can we agree the need is there? Can we do something together? When we work with such a large group, again, the Biodesics team works to implement really data sharing infrastructure. We want to make sure that there's very strict compliance, that when this company works with any primary care groups, there's nothing to suggest that you have to ever order a test. You certainly don't ever have to directly refer to me or any other directed physician. This is not about tests or increasing referrals or increasing biopsies. This is educating your primary care and even general pulmonary about how should we assess risk, and could we do a better job at picking out that needle in a haystack. The next thing we did was build an operational plan. So if you think about multiple clinic locations, multiple physicians, things can get pretty tricky pretty quickly. So the Biodesics team was very diligent to say, let's first identify some program leads. So they have a physician lead, they have a mid-level lead, they have an MA lead, and then they have the practice manager who's very aware of any billing issues and kind of understands the whole thing. Define sample collection. So the Biodesics team teaches the MAs, mid-levels, and even the providers, if they want to, on sample collection, and we'll talk about that. We'll talk about the ordering process. And what we've encouraged physicians to do when you do look under the hood, and first and foremost, is start today, right? Just start. Have that conversation. So the next patient you see with nodule, calculate that risk. Figure out if that nodule's growing or what their characteristics are. and make those referrals, certainly if they're higher risk up front. And then if you're going to do a broader look back, probably the most logical thing to do is start with the people you've seen most recently. So look back 30 days, 60 days, 90 days. Figure out how many patients are there. This does not mean that you have performed malpractice. It does not mean that you have done anything wrong. 70% of patients in the country are not getting guidelines follow-up, okay? You are all busy. We get it. So when you call the patient, I would just say, again, we realize that you have a nodule. We have now learned about a way to evaluate your nodule to get more specific information about whether you need more assistance or evaluation. Reminding them again, most nodules are benign, but we'd love to know more about yours in case yours is one to be concerned about. When you have to think about how to scale to cover something like this with 3,000 patients, Biodesic's team will work on how do we do this, right? We can't eat the whole elephant at once, you know, so let's, and for this particular clinic, their thought is that they would test 10 patients a week, have just a couple of patients come in per day. And then the other important thing is report out. We really want to have bi-directional communication so that you guys understand what's happening with the patients with positive results, and also looking at those with negative results and making sure we're keeping track and what those report out intervals would like to be. So this is one example of how this might work. Next slide. Let's go to the order. I think we have the blood draw. So again, we try to just simplify this. So I really wanted just to share a real world application. When you're trying to find patients to surveil or refer without Nodify, it's really like truly trying to find a true needle in a haystack. What we want is to make that needle obvious. And if we can make that obvious on the primary care side, where you know if it's above 5%, your blood test can't reassure me, I need you to see somebody. Could we do something special together? I truly think we can. Next slide. I say that because I've been working with this since 2020. And when we talk about early stage cancer, I want to spend the majority of my time doing bronchoscopy on patients with malignant disease. I look at my own data routinely, and I've been using this test now for several years. My biopsies, only 27% of what I do is benign disease. And when I tell physicians that as a proceduralist or a lung doctor that may be listening to this, if you talk to your primary care providers and say, I really want to responsibly handle nodules, and you can show them that your stage in your hospital is increasing. So if that patient enters your hospital system and you evaluate them and risk stratify them, ideally, the goal is that we all will be finding earlier stage in the United States. Next slide. The test itself, you've got a traditional blood draw, and then you also have a single-use blood lancing device. It's called the Tasso device. It's kind of like a little capillary draw. So super easy. You don't have to have any phlebotomy in your office. The roadmap as far as the order form can be done via a portal, and the Biodesic's team can walk you through this. It is not difficult in any manner.